College Vellore to chair the session on CTD ILDs.
Good afternoon, friends. Thanks for inviting our rheumatology department for this session. For the next 70 minutes, I think we have 3 talks. The first by Dr. Kavitha, second by Dr. Priya, and third by Dr. Bani. So I would invite Dr. Kavitha, who is Associate Professor of Pulmonary Medicine at St. John Medical College. And she has many professional achievements to her credit. She is a faculty for the ATS MECOR, Diplomate of World Sleep Society, and faculty of the World Sleep Academy. And she has many publications in national and international journals. Over to you, Dr. Kavitha.
Thank you, sir. So I think the crowd has gone a bit quiet for the last few talks. So let's please revive some answers now. So from unknown entities, from idiopathic entities, we move on to ILDs which have a known cause. But of course, knowing the cause doesn't help us much. These are also as difficult to treat as the other entities. Like Dr. Bani was saying, there are a lot of gray areas, much more in these entities because we do not have strong evidence base for the management, and most of the management is extrapolated from what we have observed in systemic sclerosis to other CTD ILDs also. So the overview of this presentation, I'll be covering both screening and management, and as the topic itself said, ACR, ACCP guidelines, so most of it will be centered around it, but since those guidelines are not very comprehensive and do not give us when to treat a patient and how to treat a patient, I'll be covering other guidelines also. So one very good thing about these guidelines that have come up is that they have included the patient community also. The patients have also participated in these guidelines, and they have come up with their preferences with respect to the investigations and the treatment, which is the need of the hour for any guideline in today's era. We need to take into considerations the patient's preferences and their experiences also. So when we talk about CTD ILDs, as you can see, the disease is extremely heterogeneous. There are a lot of CTDs, a lot of different ILDs, different ILDs overlap, and we have a combination of, So we have a combination of these different CTDs and different ILD patterns that we have seen since morning, and the course, the natural course of the disease itself and how the patient behaves varies with each patient. So this was seen in the epidemiology, the first talk that Dr. Christopher spoke about. So how important are CTD ILDs? In the 2 major registries that we have from India, it comprised of about 20% of the cases, including the PGI1 and the India ILD registry. Even in the ongoing INPF registry also, so far whatever data we have, it comprises about 20 to 30%. So it is fair enough to say 1/3 of your cases are going to be CTD ILDs, so it is very important to know how to manage them. Like I said, lot of CTDs and lot of ILD patterns, cannot cover everything in 25 minutes. So I'll be concentrating mainly on the 3 most common entities that you may come across. One is definitely systemic sclerosis ILD. Like I said, most of the evidence comes from there because all the studies are done there, and all the management is extrapolated from what we know from systemic sclerosis ILD. RA ILD, which is probably very common because RA itself is the most common. And nowadays, more identified entity is the myositis ILD, and it is very fascinating at present to know about it. So what is the relevance of these CTD ILDs? Why should I know if it is a CTD underlying the ILD or it is an idiopathic entity? One, because the treatment varies, the prognosis varies, and you need to be aware of the extrapulmonary manifestations of the CTD and how to treat that as well in a patient with a CTD ILD, unlike a patient who has only ILD or idiopathic variety of the ILDs. So when do I start suspecting that this patient may have CTD? Some of the pointers come from the patient demographics, the clinical features. The radiology and histopathology will also give me a clue. So when do I start suspecting that this patient may have CTD-ILD? There are certain criteria that I would like to let you know. It is also important to have a multidisciplinary team here also. Though I know that this is a CTD underlying and this is causing the ILD, the most important person here will probably be the rheumatologist, because they have more experience with screening for the extrapulmonary manifestations and also with the treatment aspect of it. Some drugs that which probably we have started using recently now with calcineurin inhibitors, tacrolimus and all that, they are more experienced with using them and the side effects of those drugs. So this figure I put up to show that if you involve a rheumatologist in the MDT, the diagnosis may change for many of the ILDs that you may not have thought of as a CTD-ILD. So it is very important to include the rheumatologist whenever there is a suspicion of a CTD-ILD. So like I was saying, there are demographic features which make me think of a CTD-ILD. There are radiological features and there are histopathological features. So what are those? Especially when I see a woman, a young aged woman less than 50 years, I suspect a CTD-ILD. A patient who has come with ILD has extrathoracic manifestations of CTD, of which this is not a comprehensive list obviously, but the most strong pointers I would say towards CTD-ILDs are if you find any of these, like Raynaud's phenomenon, mechanics hands, we'll see all these in the cases that we will discuss. But these are some of the strong pointers towards CTD-ILDs. NSIP pattern or OP pattern, which was discussed just now, always rule out a CTD-ILD. And if you have multi-compartmental involvement, be it on radiology or on histopathology, if you have involvement of the pleura, the pericardium, including with the ILD per se, or if you have coexistent pulmonary hypertension or esophageal involvement, all these are pointers towards a probable underlying CTD, and our autoimmune profile also will help. Radiology was dealt with in the morning. This is just a recap. Some radiological features that may point towards an underlying CTD are a straight edge sign, which was shown in the morning. These are all for UIB pattern of CTD-ILD. Exuberant honeycombing, where you have extensive honeycombing involving the fibrotic areas. You have anterior upper lobe sign and the four corners sign. This was dealt with in the radiology talk. So now, coming to the screening. So these are two case scenarios, small bits of it. One, we have a young male who is newly diagnosed with diffuse cutaneous systemic sclerosis with anti-ACL70 positivity. And in another, you have a 35-year-old female with limited cutaneous systemic sclerosis since 6 years with centromere positivity. Which patient would you like to screen for ILD? A 35-year-old female. How many for the females? One hand, only one hand. Okay. How many for the male patient? Okay, lots more. Okay. So, of course, systemic sclerosis is a CTD which has a lot of propensity to develop ILD. But it is important, why I have put up this is, it is important as clinicians to know the risk factors for development and progression of ILDs in patients with underlying CTD. So, of course, the patient here who has more propensity to develop CTD is the first patient, but does not mean that you should not screen the other patient also. Screening is something that is a clinician's perspective, that you should have a high index of suspicion in every patient with an underlying CTD to screen for an ILD patient. So male patients, diffuse cutaneous systemic sclerosis, anti-ACL70 positivity, earlier diagnosis of systemic sclerosis, that is newly diagnosed or within 5 years or 7 years of a onset of the disease, all these are risk factors for development of ILD. It is said that as the disease progresses, that is after some 5 to 10 years of the disease, development of ILD becomes lesser and lesser. So if they do develop ILD, they do it earlier in the course of the disease. Coming to the second, 40-year-old female with rheumatoid arthritis with quiescent joint disease with anti-CCP of 18, and a 50-year-old male smoker with active arthritis and elevated anti-CCP. Here, the first patient or the second patient has more propensity for ILD. Yes, I hear some seconds. If it is louder, it will be good. So the second patient, because active arthritis, male patient, smoker, and high titers of anti-CCP. All these again risk factors for development of rheumatoid arthritis ILD. And this is a myositis. We'll come to it later. So like I said, in any patient with CTD, it's important to know the risk factors. In systemic sclerosis, I already told you, diffuse involvement, males, early disease, and anti-topoisomerase positivity or anti-SCL70 positivity. In patients with myositis, underlying myositis, any anti-synthetase syndromes, anti-MDA5 positivity, overlap myositis with PMSCL70 positivity, all these are risk factors for ILD development. And in rheumatoid arthritis patients, males, smokers, and high titers and active joint disease are important risk factors. So these risk factors are important to know. It does not mean that in patients who don't have these risk factors, I'll forget about the ILD, but these are some things that will keep my antenna high and my suspicion high to screen for ILD. So we know whom to screen. How do you want to screen them? There are multiple tests that are available clinically. Of course, every time you see a patient, you examine the patient, you ask for history of any dyspnea, you auscultate the patient for any crepitations. You can do a chest X-ray, you have PFTs under your disposal, you have HRCT, and you have walk tests. So which is the best method for screening? Anybody can give a louder answer? CT scan, okay. Will you do CT every time you have a suspicion, every time the patient comes? That's not possible, right? Yes, CT is the best modality available in today's era because, of course, clinical and chest X-ray is not the ideal modality at all. All of us know that all the lung fields are not seen on the chest X-ray and most of it is obscure. So PFT and HRCT as a combined modality is what is recommended because they have complementary information to each other. CT will tell you the extent of involvement, the pattern of ILD, and PFT will tell you the impact, the physiological impact that the ILD has. But most of the times, all of us first resort to, in clinical practice, resort to clinical examination and PFTs and then think of the CT scans. But yes, in a high suspicion patient, HRCT combined with PFT is what is recommended. Lung ultrasound, of course, not a part of the guidelines, but as pulmonologists, we are used to using lung ultrasound now in critical care and in other areas of care. So it has been coming up as a modality for both screening and diagnosis of ILD. Most of the common findings that are there are irregular pleural line and B lines. More than 10 B lines is what is considered as a positive screen for ILD. So if you have the expertise and if you have the availability of ultrasound, yes, you can use lung ultrasound also as a good screening modality, though it is not the recommended modality because probably the expertise is not that great yet in this area. So coming to screening, summarizing that, in a patient with an underlying autoimmune rheumatic disease, if there are risk factors, then do the PFT and HRCT. If there are no risk factors and the patient is asymptomatic and your clinical screen is negative, you can test only if the patient is symptomatic. If you find an ILD, then periodic PFTs and ambulatory testing and HRCT as needed may be done. So this is about screening. We'll start with the cases now. So this is the first case. This is a 32-year-old female, a newly diagnosed systemic sclerosis patient. As you can see, there is sclerodactyly and skin thickening which is extending beyond the elbow, so diffuse cutaneous involvement, and anti-SCL70 is positive. This is her PFT. I will not ask you to interpret the PFTs. I hope that is because that is not the main concern here. So as you can see, it is a normal PFT with a fair enough 6-minute walk distance with no significant desaturation. So since the patient has a high risk for developing ILD, we did a CT scan. This is the CT. It is running a bit fast, but it is going again and again. So you can have a look. What does it show? At least the pattern now. No loudspeakers, you all need mics attached to you. Call the mics to be given to all the delegates. What pattern? NSIP, okay. So NSIP pattern is there, but it is very, very minimal. Only the basal zones are involved. The rest of the lung is pretty much spared. So what would you want to do next? Out of these 4 options, do you want to start the patient on treatment with steroids and MMF, or just MMF, nintedanib, which is most of the time the practice that we see. Any ILD patient comes to us with a prescription of nintedanib today, or you just want to monitor the patient. A? Somebody is raising hands for A, okay. B? One taker for B. C? Nobody, that's very good. D? Okay, many for D. Okay, yes, this patient is asymptomatic. He has very minimal ILD on CT scan, less than 10% involvement, on eyeballing, obviously not the right way of doing the fibrosis score, but on eyeballing it looks like it is less than 10%. Patient is asymptomatic. Pulmonary functions are normal. There is no desaturation on ambulatory testing. I would wait and watch in this patient as per recommendations also. That is the preferred modality. So I decide to wait for 3 months and see how the patient behaves and then take a call of what to do. I ask the patient to come after 3 months for a repeat PFT. But as all our patients would do, the patient decides to come after a year, once they develop symptoms. That's how our patients behave. They never come for regular follow-up. They don't come to you unless they are symptomatic. So 1 year later, when the patient comes, I again do the PFT. I find that, as obvious, the lung functions have deteriorated. DLCO has gone down and the 6-minute walk test has also come down with some desaturation. I repeat the PFT to see what has happened. So as you can see, there is some progression of the ILD. And it is still an NSIP pattern, and as was discussed in the morning, you can see the esophageal dilatation and all that pointing towards, here we know that it is a CTD-ILD. So what would you want to do now? The same options. A, B. Okay. So this is a debatable thing now, whether you want to give steroids or you don't want to give steroids. At present, there is nothing acute happening in the patient, and in patients with an underlying systemic sclerosis, you have to be very, very wary of using steroids. It is not a, what do I say, it is definitely, it's not that you should never use steroids, but you have to be very careful when you give steroids to patients with underlying systemic sclerosis. Even in patients with MCTD or myositis which have a systemic sclerosis overlap, you have to be very, very careful. Use the lowest possible dose of steroids. Why do we actually start steroids for patients with CTD-ILDs? Because it has a rapid onset of action. You want something to act fast so that you have time till the MMF or other immunomodulator that you are starting starts acting. Till then you want to have something that will tide over that episode of crisis that you want to act upon. Here the patient is come to you as a regular follow-up. Of course she has come late, but she's not really that symptomatic and there is no hurry in treating the patient. So you can either choose to give a very short course of small dose steroids, 10 to 15 mg, but otherwise you can just start with immunomodulators and let it act also. Like I said, in CTD-ILDs, there is no definite rule. There are a lot of gray areas on what to use and when to use, how much to use. So most of the evidence is seen in this table. I'm not going into any of the trials, but it is important to know that there are so many trials that have been done, and most of this evidence is what we are using to treat other CTD-ILDs as well. So as we can see, cyclophosphamide and MMF have equal efficacy in treating, and because MMF has lesser side effect profile, it is more favored in today's era as the treatment modality of choice. So I start the patient on MMF. At treatment initiation, this was what she came with after 1 year of follow-up, and 6 months later, patient comes back to me and says, I am fine, I have no problems, it has not progressed, there is no progression of symptoms, but I repeat a PFT and this is what it shows. What has happened? Has the patient worsened? Yes. How many yes? Few hands I can see. How many say there is no worsening? We are not talking about progressive pulmonary fibrosis at all over here. Don't go into that definition. That will be some other talk. I'm just asking, has it worsened or not? Yes, that's a very good observation. So please be careful when your patients come to you for follow-up. Please make sure that the demographics that have been entered in the PFT are the same. The height and the age of the patient are entered properly. Sometimes there may be a misentry or something else is entered and the reference value has changed. If you just see the percentage predicted, it will always feel like it has probably worsened, but if you see the actual values, there is not much of a difference and the patient is clinically stable. So that is also a pointer towards something that has gone wrong technically. So always be careful to use the same reference equations in your PFT machines, use the same machine preferably, and make sure that the demographics entered are properly entered. So summarizing systemic sclerosis ILD management, I'll run through it a bit fast. So if there is significant involvement, that is FVC is less than 70% or HRCT shows more than 20% involvement, then you treat them, and if there is progression, you can choose the drugs accordingly. Today's in the guideline that we are looking at present, mycophenolate is the drug of choice because the side effect profile and the efficacy are good enough. This is summarizing the same thing. So coming to the second case, so this is a male patient with rheumatoid arthritis on methotrexate 15 mg per week, has come to you with clinical features suggestive of ILD. You have Velcro crackles, you have room air hypoxia, and you have your PFT showing restrictive physiology and decreased DLCO as well. So this is the CT pattern again. What pattern is it? UIP. Okay. So UIP, most common pattern seen in RA-ILD, male patient more likely to develop. So what are the possibilities we have here? It can be RA-related ILD. Can it be methotrexate-induced ILD? Yes. Okay. It can be IPF. Unlikely. That will be my last differential because the patient has an underlying CTD. Methotrexate-induced ILD again is one more gray area. Some people have, today's most of the evidence shows that methotrexate causing a fibrotic ILD is very unlikely. In fact, patients who are on methotrexate may not progress to ILD as faster as patients who are not on underlying treatment. Controlling the articular involvement with proper DMARDs, of which methotrexate is an important DMARD, is more important to prevent the ILD onset and progression in these patients. Of course, methotrexate-induced pneumonitis is a different entity where you have acute pneumonitis. That is a possibility, but methotrexate as such causing fibrotic ILD is less likely as per evidence in today's era. So you don't have to be very scared about methotrexate, but if the patient has a very significant underlying ILD, of course, starting methotrexate may be a problem because methotrexate-induced pneumonitis, no matter how rare it is, it can happen. Okay. So this is about RA-ILD, the management, DMARDs, and choice of immunomodulators will be the same as systemic sclerosis, MMF being the first choice again here. This is our third case, the last case. So it is a female patient who has come with 2 weeks history of progressive dyspnea, no CTD symptoms underlying. This is the CT which she came with. She has received antivirals and antibiotics outside, has not responded, has come in respiratory failure, required intubation, stayed in the hospital for nearly a month to recover from this, and she was discharged. During the course of that ARDS management, of course, she received steroids also, and it was continued and being tapered. So she was reviewed after 2 weeks of discharge, that is almost 6 weeks into the illness. And this is the CT now. She is better, though she is still on oxygen. As we can see, the CT has improved, but she complains of proximal muscle weakness. Now we are in a dilemma of whether this is myositis or this is ICU-acquired weakness. This is a classical case that we would all see in our practice. So when you examine her closely, she showed some skin lesions. What are these? What are these? Gordon's papules. So it is very important to look at the patient's hands, especially in myositis. We have seen that hands give a lot of information. So please look at the hands of the patient. So we did a myoblot which showed that anti-PL7 was positive. Heliotrope rash may be very difficult to pick up in our patients. Gordon's papules and mechanics hands is something that is very classically seen if you look for it. So in female patients especially, you may brush it aside as contact dermatitis, but have a high index of suspicion in a patient, especially with an underlying ILD, if there is an NSIP-OP overlap especially, and inverse Gordon papules and ulcerations. If you see ulcerations like this, more pointing towards MDA5 associated disease. Lot of antibodies are there, but what we need to know is antisynthetase syndrome and MDA5 ILD are more prone to progress faster, and you saw that they can come with an ARDS-like presentation. One very important point that I want to stress here is ANA may be negative. ANA negative alone in a patient with an underlying suspicion of myositis does not rule out myositis. ANA can be negative in these patients. We generally use ANA as a screening modality, but just because ANA is negative, don't say it is not myositis. It can be myositis as well. So again, the treatment in myositis associated ILD, it has to be a more aggressive management. Like I said, in these patients, you really need a rheumatologist's help to deal with these patients, because the drugs that are being used they are more experienced with using these drugs. So treatment decision in any CTD ILD will depend on the underlying subtype of the CTD, the severity of the ILD, the extrapulmonary manifestations, and patient factors and drugs. Please know your drugs and the complications that the drugs can cause. Yes, finishing, last slide. And ancillary management of PJP prophylaxis and rehabilitation is also important. So to take home points from this are, you should know the clinical course of the disease, what are the risk factors, and what are the extrapulmonary manifestations which can point towards these diseases. Guidelines are not set in stone. Every patient needs to be individualized, especially in these cases, because the underlying evidence is not very strong. Thank you.
Thanks. Thanks, Dr. Kavitha, for that comprehensive review in this short time. Any questions? We are short of time, but I think can take a couple of questions.
Just a small and practical question. Like, suppose a patient of systemic sclerosis with acute exacerbation coming to ICU. So can we use high-dose steroids in those patients for 5 to 7 days? Because as we always know that systemic sclerosis is, going to be in renal crisis or so.
Acute exacerbation is a different scenario where you are forced to use steroids. Like I said, it's not always a no for systemic sclerosis and steroids, but you have to be as short duration and as careful as possible. In an acute exacerbation, yes, you have to start with steroids and then move to the other drugs.
Shall I just make a couple of comments maybe?
Sure.
As Dr. Kavitha had highlighted, ACR ACCP guidelines is something made on a boardroom where people with low-grade recommendations, and it's not for management of an individual patient, it's for recommendations by the body. That's my first comment. And second is, again, it's made for the American community, even though 3 of those authors were from Indian origin, but this for American setup. Second is, generally, we tend to do HRCT for all systemic sclerosis patients because maybe we are in a tertiary center, but still 80 to 85% of them have lung changes. And it not only helps your ILD, it helps to look for esophageal changes, and of course quantifying the pulmonary artery size. So that helps. And third comment is about steroids in systemic sclerosis. Generally, people tend to keep low, maybe below 15 mg of prednisolone, but still in a given patient, for us in our department for the past 15 years, we have only seen 2 patients with renal crisis. So in an individual patient, definitely we can use it. But there are a few conditions we won't use it. If it's a male patient, if he has an RNA polymerase positive, or if the patient already has a blood pressure which is high, or elderly. So those are situations which have high risk of renal crisis, so we may not use that. And third thing for the MDA5, again, all these diseases have a strong genetic predisposition as well. So many of the data which we have from MDA5, like from the Eastern populations like Japanese, Chinese, shows a high rate of rapidly progressive ILD and mortality, which is very different from, we had 29 patients, of which the mortality was only 2, and while the Japanese, Chinese data was almost like 30%. So maybe the genetics also play in a response to how they respond to treatment or how they manifest. But for us, anti-MDA5, it's a more aggressive skin disease than a lung disease. And only 60% had lung disease itself in the MDA5. So maybe difference in populations on how they manifest and how they respond. So that's probably briefly about what I could comment. Thank you very much.
Thank you, thank you.
The next session we have Dr. Priya, who is an Associate Professor of Pulmonary Medicine at CMC. She has the APCCM Gold Medal Award for the postgraduates. She has got a Young Faculty Research Award in NAPCON 2019 for oral presentation, and which is a long-term 11-year retrospective study. And again in 2020, she had the first prize of oral presentation, and that was basically for a study on lung cancer in a tertiary care center. Over to Dr. Priya.